All right, welcome everybody. We're going to go ahead and kick off the afternoon here. Hopefully everyone had a great lunch and is all fueled up for the session that we're about to kick off into. Zach, go ahead and have us go ahead and start. We are about to enter the session engaging participants as partners in research, data, and its use. Want to welcome all of the panelists here to join me, and I want to give a huge thanks to the organizers for the invitation and the ability to participate today. And most importantly, I actually want to thank all of you for participating today. It's really your voices that we want to hear. We want to listen to what you have to say. We want to learn from you. So my name is Adam Berger. I'm the director of the Division of Clinical and Healthcare Research Policy in the Office of Science Policy. That's part of the director's office here at NIH. In short, I get to oversee all the policies that impact human beings here at the agency. So it's a real pleasure to be with you. I'm going to pass this on since I have no slides. I recognize that you guys don't really want to hear from me. You want to hear from all of them. So I'm going to keep it that way. To answer Walter's earlier question this morning about whether we're paying attention to the great work that's going on here at NINDS around participant engagement, the short answer is absolutely yes. We want to leverage that work. We want to leverage the work of others to be able to meaningfully engage people and communities. We also recognize that there isn't a one-size-fits-all approach here, and that engagement is going to need to be tailored to the needs and experiences of both people and communities themselves. So it's critical that we recognize that it truly is research participants that empower the research enterprise here. And that's not only by participating in research, but by allowing us to be stewards of their data, by entrusting us with their data, and by holding us accountable to how that data is used. So we have a great lineup of speakers here today. And they're going to dissect out the intersects between participation in research, benefiting from research, and research participants as equal partners in research and participant data. So our panelists are Shilpa Venkachalam from Creaky Joints Global Health Living Foundation, and Shilpa, I am sorry for butchering your last name there, Amir Bahmani from Stanford University, Kyle Brothers from University of Illinois School of Medicine, Kareem Watson from all of us. You can read more about them and their bios on the presenters page of the forum site. I personally just don't like to use up the valuable time listening to them and the ability to hear from you by going through them all. So please go look at all of them. They are really impressive folks. In putting their talks together, panelists have considered a number of topics, including connecting the data needs of researchers with the interest, goals, and outcomes of interest of participants. Participants as partners in research, including having an equal voice in what and how data are used for research, establishing and maintaining the connection between participants and researchers, ensuring that the research enterprise is trustworthy so that participants may be willing to trust us with their data, and returning value to participants and ensuring privacy and confidentiality when using participant data in research. So with that, we're going to go ahead and jump in, and we're going to start off with Shilpa. And Shilpa, you can either go from there or you can come up here. It's your choice. But they did hand me this, so I need to hand this off. So.
Thank you, Adam. So thank you very much for having me here today. And let me just get these slides sorted so I don't make a blunder. Thank you. So one of our commitments has been, this push to integrate real-world data with EHR data, with clinical data, and with lab work. And so that's what I'm here to talk about, which is why I framed this talk as a new era of collaborative research, where we're inviting patients as equal stakeholders to participate in the research process. So what is Patient Spot, right? We are a patient-powered digital platform. We're an omni-disease platform. We serve patients living with all forms of chronic diseases. The platform itself functions as a research registry as well. And so we're able to collect patient-generated data to do comparative effectiveness research, safety research, efficacy research, right? Now, alongside this, we place a heavy importance in sharing back that research, in sharing back that data with the community, most importantly, in the ways that they want it, right? So there is no point in disseminating data, no point in disseminating research if end users, in this case patients, are not able to use them to make informed medical decisions. And so our push is always to curate information in a way that patients are able to then use it at point of care. So, the registry itself was set up in 2015 with initial support by the Patient-Centered Outcomes Research Institute. These were set up as a collaboration or a conglomeration of what we call patient-powered research networks. I'm a patient myself. I live with rheumatoid arthritis. I am the principal investigator of this registry. And part of the reason we set this up is to bring patients into the research process, to have a very active voice, to amplify their voice alongside clinicians and healthcare stakeholders. So the way we set it up was through a collaboration in terms of, and when I say set it up, I mean, everything from design to interface to what kind of data should be collected to what our consent form needs to look like so that patients are not intimidated by consent forms, to explain in the consent form what happens to your data when you supply that data, who sees your data, how long is the data stored, what happens after 3 or 4 years when you provide that data, and what kind of retrospective analysis are we allowed to do with the permission of the patient community. And so this became a hub for patient-centric resources as well. Most importantly, to share, I'll say one of the most interesting things about collecting patient-reported outcomes research data is it serves as a needs assessment. So when we see that patients are completing assessments about fatigue, about things that cannot be seen on your blood work, pain, for example, right? The real world experience, we know what kind of information to share back. So this kind of, constant sort of give and take between researchers, between clinicians, right? And the patient community is pivotal for us to be able to share back what the community needs, and thereby to constantly engage and motivate participation by the community in research. So the infrastructure itself, the registry infrastructure itself is so set up that we're able to make very rapid changes and customize it as per the needs of researchers. We partner with academic institutions, with institutions like the NIH, with PCORI, with FDA. We've been doing a lot of work with them. We're able to also link to external data systems, health system EHRs, claims data. We're able to collect passive data through biosensors, so smartwatches, for example, and then we're able to triangulate all that data with clinical data, with PROs, et cetera. So these are all novel data collection techniques that we've been engaged in. I'm going to talk a little bit about our data collection and app functionality. I'll show you a few screenshots because one of the things we found from engaging with our patients and our patient advisory boards is what the app interface looks like matters a lot to patients, right? So we want to make the app useful to patients, easy to use, and not intimidating to them. Now, we've spoken to patients over the years. One of the things they've said to us is that the traditional paradigms of research seem very daunting to them, right? 10 pages of consent, fine print that they don't even read, that they don't even understand, they don't really care about. I mean, they're already living with a chronic disease. So how do we make research more accessible and interesting to them? So one of the things we do is when we invite patients to join the research registry and the platform is we collect basic demographics with their consent, of course. We ask for their date of birth, their sex, their ethnicity, insurance status. We also ask for their doctors' names, where they reside, what state they reside in, their medications, etc. And because this is all self-reported, it's an important way for us to triangulate and validate the data, right? To validate their diagnosis. So we also collect medication data. We follow the RX norm ontology. And so patients are able to enter what medication they're taking, the frequency at which they're taking it, the dosage at which they're taking it, why they stop or pause a medication. Often chronic disease patients will pause medications, sometimes just because, sometimes because of an infection, etc. And if they switch to a new medication. I'll talk a little bit about this in a later slide, where there's a clinical use component here, where clinicians are able to use our app now for remote therapeutic monitoring. So when patients switch a medication, they're able to overlap that and overlay that, track their symptoms, fatigue, sleep, disturbance, physical function, and see how they're doing when they start a new medication. This information is, of course, very important to the clinician as well, who is then able to get direct reports from the patient and combine that with lab results. Now, this becomes very important in chronic diseases where there are ebbs and flows. For example, in rheumatic conditions like rheumatoid arthritis, we see a rheumatologist once every 3 months, sometimes once every 6 months. And so that interim period to collect the data becomes really important to understand how the patient is living with the disease. So this is what the dashboard looks like. It generates user-generated reports. So when patients pick and choose, they're able to pick and choose what symptoms they want to track. Once they track over a period of time, they're able to see how they're doing over a 7-day period, sometimes over a 30-day period, sometimes over a 90-day period. The app also generates an automatic report. A lot of chronic disease patients will tell us that a lot of their symptoms are invisible symptoms. They don't show up on a lab result. They don't show up in blood work. They don't show up in imaging. And so they're able to share this information then back with their doctor to make any kinds of adjustments in their treatment. So during onboarding, users are also prompted and encouraged to select which PROs they want to choose from. The patient-reported outcomes instruments that were actually devised by the NIH are very important for the chronic disease population, as I've said. But we also want to get patients to use them in the right way. So different chronic disease cohorts will pick different assessments to perform. And we provide some guidance on what might be the right assessments for, say, someone living with ankylosing spondylitis versus migraines. Again, here is just a visual of how the assessments appear. They're performed one at a time in a stream of single question response measures so that patients don't feel inundated with too many questions. They're adaptive questions. So for example, if someone says they can't walk 3 miles, the next question is not going to be, can you walk 10 miles? So we're responding again to whatever the patient is answering. And so it feels like a very customized approach to gather the data. It feels like it's uniquely created for the specific patient. In terms of treatment, we are able to add new treatments depending on your condition. Patients track their medications, they can change their medications, they can even set up reminders in the app to take their medications. Now, what do we do with all this data, right? We're collecting the data, we're the research community, we're the clinicians, we're the healthcare stakeholders. There's no point in us just hoarding all that data. And so we want to share back that data. And so we use data constantly in the organization to analyze it. So we have a data analytics team that is constantly looking at the data every day and thereby creating very, very targeted emails. And I shouldn't use the word targeted, sorry, but very, very specific emails, very specific educational content, so that someone who's dealing with sleep disturbance doesn't get information about fatigue. They get information about sleep disturbance, sleep hygiene, how to get better sleep, etc. So we're able to do that within the entire community. And we have within the registry more than 50,000 patients consented. But outside of the registry, for patients just using the platform, we have, I'm now forgetting the numbers, but it's a huge number. I have 5 minutes left, so I'm going to skip some of these slides. I'll say that we are able to customize our study workflows. We're doing a study with NIH on steroid use and common infections. So we're able to change the skin of the app so that patients are able to participate based on inclusion-exclusion criteria. We don't just ask all patients to participate in the studies. And then finally, I want to bring us to, some of the studies that we've done. Sorry for skipping some of these slides very quickly. But one of the things we've done is we're able to train patients online on how to perform, for example, joint exams on their own at home. So telehealth is something that is gaining a lot of importance with chronic disease populations. And so we're able to allow clinicians to conduct joint exams, for example, at home. We are also able to track, we did studies, to gather real world evidence where we wanted patients to pick and choose based on their disease, what symptoms were important to them, and then share back that data with their doctors and with their communities. And so this was presented at the American College of Rheumatology. Likewise, we did a study that was collecting biosensor data, so passive data through a smartwatch, which we then triangulated. So, patients often experience flares, and during flares, they may have high levels of fatigue, they may not move very much. And so their watch is collecting the data about their steps and their movement. We're then able to match that with what patients are telling us about their levels of fatigue, what their blood work is showing. And so by doing this, what we're really getting is an understanding of the person, not the patient, which is what patients really want today, to understand the person as a whole, not just the patient. And so again, this is some of the data that was presented at the American College of Rheumatology as well, and at the EULAR convention, which is the European League Against Rheumatology. We found there was a large percentage of adherence to passive data collection triangulated with other forms of data. And then finally, we also have the ability to use the app for remote monitoring. Clinicians are able to collect and monitor their patients when they're not seeing them, and then triage them according to the need at that given moment. We also collect unstructured data where patients are able to make notes in their symptom journal, what we call symptom journal, and sort of combine that as well, those notes as well, for a better understanding of the patient's life. So all in all, these are just some of the different pieces of data that we've been working on bringing together. It's attitudinal data, how do they perceive injections versus oral medications, or route of administration, camera data for people with skin lesions, for example, biosensor data with smartwatches, medication-related data. Are they adhering to their medications? Why are they not doing well? Why are they being suboptimally treated? And then, of course, home and work productivity data as well. How is their chronic disease impacting their work life and their home life? And then safety data. So what we're engaging in here is triangulation of these different pieces of data to get a bigger understanding, a wholer picture of the entire patient. Thank you very much.
Thank you, Shilpa. We're going to hold questions at the end, but Amir is next.
All right. Hi, everyone. It's a great pleasure to be here. Okay, great. Amir Bamani. My background is computer science, and my talk is going to be a bit different. It's going to be from the perspective of an engineer. And out of a tragedy in 2014, I lost my wife to cancer, and I ended up working in School of Medicine. So I'm going to talk about, again, a little bit more about, the gap that we have, in terms of between engineering and School of Medicine. By the way, I reached here last night from Dubai. So if I sleep, during my presentation, please wake me up. So, yeah, I want to start my presentation with this slide that, let's assume that you want to help me to move from point A to point Z, and we have different ways to get there. And in order to tell me which way is the quickest way, there are different layers of information here, right? So if I remove the traffic layer, then whatever you are going to recommend is going to be a guesstimate, right? Because you don't have access to all the layers of information. Similarly, when we're talking about human health, our health is a combination of multiple factors. Our gut bacteria, microbiome, we're talking about DNA, RNA, protein, our genes, and our lifestyle and our diet, right? Combination of these three major factors create all the small molecules in our body. Now, if you're a physician, you're a clinician, and you want to help someone to move from a disease state to a healthy state, or you want to keep them in a healthy state, then you got to get access to these layers of information, right? So we need data, right? We're moving away from hunch-based or guess-based medicine to data-driven medicine. But as we are moving away from that, we're collecting a lot of data, then your cost function rapidly changes toward computation and storage. So we collected over 2 petabytes of data around one individual, former chair of genetics at Stanford, Mike Snyder. If you want to store 1 petabyte of data on any major cloud provider today, it's going to cost you roughly around $20,000 per month. Clearly, we need better computation and storage systems, right? When we talk about deep data, multimodal data, we have a bunch of needs and challenges. The first, is around data acquisition, right? We have different sources. We want to collect data from those sources. Then we have data storage. Different layers of storage are important. Data distribution is important. Different cities, continents, countries, different regulations. And finally, data analysis, which is around AI/ML. But you have to deal at least with 3 major factors. The number one is scalability to me, sustainability is extremely important. Previously, if you wanted to publish in a high-profile journal, let's say 15 years ago, probably you could, collect like 10 patients' data, but then, you would have a kind of a chance, to get there. But today you have to show that your solution works for a large number of participants. So scalability is extremely important. We got to design latency-sensitive applications like Instagram, Twitter, right? Still call it Twitter. And, it has to be very user-friendly, like the app my colleague showed you. The second part is around interoperability. And if your solution works, for instance, for Apple Watch, it has to work for Fitbit because these are intertwined, right? And the third piece is around security and privacy, which is the foundation of any medical application. But the biggest problem, as I mentioned, I believe is the gap between engineering departments and other schools and with the School of Medicine. We need more designers, more engineers today in the School of Medicine. But there is a barrier, right? So I'll talk about that in a second. I want to start with this research example here around wearable devices, and they're very helpful. They're helping you to collect heart rate variability, a lot of important information. And this is an example that I want to talk about it around detecting infectious disease. Commercial flights, they have different phases, right? So we have climbing, cruising altitude, which is around 30 to 40,000 feet. And as we go high, the air pressure drops. FAA, Federal Aviation Administration, set the cabin pressure to 8,000 feet. So it is, like, for instance, it's between 6,000 to 8,000 feet, the cabin pressure. And let's say you are flying from here to Dubai, 13 hours, and you will have some sort of mildly hypoxic conditions, right? And so Mike Snyder did something really cool in 2016, and he started using pulse oximeter during different phases of flight. And he observed that his blood oxygen level drops a bit, as we are expecting, right? Because the cabin pressure is, it's at 8,000 feet, which is half of Mountain Kilimanjaro. So he did something really cool. He created a green zone around himself, right? Created a kind of a baseline. Found that every time that he's flying, he's going to expect something like this. But once he was flying from Frankfurt to Oslo, and he was like, what is going on? Why there's such a big shift? He didn't have any symptom, pre-symptomatic. A day after that, he developed fever. And he realized 2 weeks before this, he was in Massachusetts helping his brother to put up a fence, and he was bitten by a tick. This is a Lyme disease, right? Lyme infection. 3 days after that, he had a heated conversation with a physician, and he convinced the physician to prescribe doxycycline. And you can see that bounce back to normal after that. I met him in 2017, and he was like, Amir, we need to collect thousands of participants' data. So let's create a platform that we can do that. And we built My PhD personal health dashboard that right now we have over 10,000 participants and 37 studies running on it. We use this platform during the COVID-19, and we built multiple algorithms, and it uses a shared privacy model. So we de-identify, we tokenize the data and keep the sensitive data at the phone level. We shift data randomly for every participant, encrypt it, send it to the backend, run the algorithm, and we again encrypt the results and send it back to the phone and decrypt it, re-identify it, and present it to the participant. Now, I don't want to go through all this detail here, but there are 2 things that are super important here. One is about the power of multidisciplinary collaboration. The graph you see on the right side is called DFA, deterministic finite automata. that we as computer scientists, we use this in compiler design. So what I'm trying to say is that there are a lot of cool concepts outside of School of Medicine, right? That we can bring those to a School of Medicine to solve some problems efficiently. But again, there's an education piece that, I'll talk about it in a second. The second piece here is that this algorithm is not perfect. The sensitivity is 80%, right? So it cannot distinguish between flu versus, for instance, COVID-19. However, there is an equilibrium between affordability and sensitivity and accuracy, right? So you could definitely add more data types to the watch, but as you are adding more sensors, then your watch is going to be very expensive. And who is going to get hurt? The underserved community, right? So what I think, here is that we need to go with some sort of like a smart data collection ways, in a way that simple solutions like this could help us to detect some of these, issues at earliest stage. And then the clinicians and physicians would be able to follow up and help the patient and collect, more data types. So the other thing that I want to bring up is around precision education. And like I said, I believe in order to deliver precision medicine, we need to work on precision education, personalized education. 2020, we published this paper in Nature Biomedical Engineering, and the paper got access over 100,000 times in the first couple of months. At the bottom of the paper, these Nature papers, as you know, there are two sections, data availability and code availability. And people had to go ahead and download the data set. They may not even have enough storage. They have to configure the code, install a lot of libraries, and they may not even have the computing power, especially underserved communities are getting impacted by this. So we came up with this idea of a cloud-based platform that with one click, everything is containerized. You can get access to the code and data. Then I built 9 modules around this and started teaching at Stanford. My students are from computer science, engineering, physicians, pretty much a very diverse background. But then I realized something is still missing. When we talk about the field of precision medicine, or let's say data-driven medicine, we are dealing with at least 3 major buckets. One bucket is around data, that clinicians, physicians are very good in that. One bucket is around probabilities and distributions, that statisticians are very good in that. And one bucket is around technology, that computer scientists, engineers are very good in that. So if you start from the research paper and combine all these topics together, then it's going to be pretty overwhelming for people who are coming from different disciplines. So we came up with a network and modular platform that right now we created 2 courses online that we are offering to students. And I'm very honored we have over 700 underserved students on our platform that they are getting certificate for free from all 50 states and 42 countries. And the last thing that I want to bring up, the last 2 slides, is you can see that this is a pretty complex field, right? It's very multidisciplinary. Now the question is, can non-technical participants also learn about their data? And speaking of large language models, we think this technology could definitely help a lot. And of course, with a proper implementation, with a set of guardrails, make it user-friendly, guided tutorials, and interactive platform, this is what we did. We built something that it's a AI visualization tool that participants or learners, let's say here, they can bring their own data. In this case, the learner brought their own CSV file around heart rate. And then we summarize this for every column, minimum, maximum, average, and send it to a large language model, ask large language model to give us some goals to visualize this data set. And then once the participants select that, it will generate a code completely, right? No programming here. And our system will run the code and give them this plot here. So you see that, there's a lot here being, handled, and it's, of course, it's a research in progress, but such technologies can be very helpful, especially like for, different languages we can use and other areas that we can customize it based on user preferences. But there are also privacy concerns here. We have tested like multiple different ways, like we are talking about sharing data summaries instead of sharing raw data. We can go with the data summaries and to reduce the risk of re-identification. The other thing is around only a shared privacy model, keeps sensitive data at the phone level, or even run large language model on the phone. And the other one is around secure cloud deployment. GPT-4 is available on Azure, and you can run it on Microsoft Azure in a secure environment. Also, Cloud 3 and 3.5 available on my AWS Bedrock. So again, you could control your data. And the last piece is around privacy agreements that it ensures that agreement between the participants and data for model training. So we can ask the company to not train it like OpenAI, for instance. These are definitely, there are several models here, but we should definitely provide a range of options to our participants and give them transparency to choose the model that works best for them. The last thing that I want to say is around beyond code or empowering problem solving. And this is a figure from our COVID-19 Nature Medicine paper. And this is just a prompt that it's like magic. We were able to, with one prompt, generate this plot that would take you hours to figure it out, right? So I think, we are kind of entering a new phase. I would call it algorithmic thinking, in a way that we need to work, instead of dealing with debugging, installing libraries, that kind of things that are not very, super valuable in terms of our time, work more toward problem solving and breaking down a problem into a set of logical steps, and teach learners and participants and empower researchers to be able to do this kind of analysis. Yeah, this is my presentation and looking forward to the discussion. Thank you.
Thanks, Amir. Certainly no code programming certainly democratizes access to these technologies. Next up is going to be Kyle Brothers.
Okay. Hello, everybody. Also very glad to be here, and especially after we saw each other's slides beforehand, but after hearing you all talk, I'm especially excited to kind of fit all this together into one panel. So I'm going to be talking about return of individual research results, and to start basically with the definition. This is the idea that research teams are collecting data from research participants, and then some of that looks like a result of some sort. Some of it might be very similar to a healthcare related diagnostic test or something like that. And the idea is about returning that information collected in the course of research or generated through the research to the individual participant from which that data came. So just kind of drawing some distinctions here. There's been talk for a long time about return of aggregate research results. Could be done through sort of a newsletter framework where you're communicating back with participants about this is what the research is doing, this is what we're finding. That's a different kind of thing from giving people their own research results. There's an idea of return of value, which is sort of like a bigger concept than return of results. I think this came from all of us. I think that's where the idea came about to think about this. This is really saying, yeah, we can help folks out by giving them their research results, but there may be other ways to sort of make participating in research valuable to individuals. And so this is just the kind of the broader concept. And then this is distinguished from disclosing clinical results directly to, in that case, patients. Which is required under the 21st Century Cures Act. And as you all probably have personally experienced, there's MyChart, you can see your results. A lot of laboratories have their own portals where patients can go and look at their results. It's a slightly different thing. And from a policy perspective, a very different thing to return a person's clinical results to them versus their research results. Okay, so with those kinds of concepts in mind, let's move on to talking about this. Why would researchers want to disclose research results to the participants from whom that data came? So one is sort of an instrumental value to research. That is that people are more willing to participate in research when they derive some sort of value from it, right? But there's also an inherent value to doing this. It's sort of demonstrating the virtues of transparency and reciprocity, which is sort of makes a research team or research organization worthy of participants' trust, right? And then of course there is, researchers are generally doing research because they want to help people. And so this is creating sort of a shorter term way to help participants, even though the research is also focused on sort of societal benefit in the longer term. Okay, so for like 15 years in bioethics, I've been attending lectures where there's sort of debates over whether or not we should be doing this. I think the debate is effectively over. There is no longer a question about whether we should disclose individual research results to participants. But really the question is how to do this. And the goal is to do it in a way that maximizes benefits to participants and preserves the scientific mission of the research, which are not always in conflict with one another. Sometimes the science does better when there's more openness, right? We kind of, the whole day's been about that. But you do have to weigh sort of, if we're spending a lot of time on this, are we also doing the other thing, the science of coming up with better understanding of disease and hopefully benefiting society in the long term, right? So there can be a trade-off. Okay, so I'm just going to go through a few sort of general challenges with doing this from the perspective of researchers. And then we'll kind of talk about some solutions that I think go back to that question of how should this be done. So, you know, there is an approach to return of results which basically says, yeah, I'll send you a data file, right? Or something like that. Here's an Excel spreadsheet. That is not that helpful, right? That very few of us are capable of analyzing that data. I worked in genetics for over a decade, but if you sent me an Excel spreadsheet with my genetic results, I would have no idea what to do with it, right? So really results with no context have very limited value to participants. And even though there has been debates in bioethics about whether we might scare people and create harms, I don't think major harms are an issue, but there are sort of low-grade harms like annoyance, uncertainty, mistaken conclusions that folks could get from getting data with no context around it. So really researchers need ways to give information, the context to help it be useful to participants, ideally tailored to an individual's results. So not just, you know, high is bad, low is good, but sort of your result was high and that is bad, right? Sort of tailoring it specifically to the person's result. Okay, the next one is analytical validity. Keep in mind when you're doing research, the labs that do that versus the clinical labs that do diagnostic testing and other kinds of clinical testing, they're there for different reasons. They have different goals, and they often operate in ways that are subtly different, right? So in a research lab, you might have a tray with a bunch of vials there, but you would never do that in a clinical lab because you have to be very careful about the handling and transfer of those materials from one place to the next. So there's all of these like very subtle ways that when you generate data through research, you might sort of create problems where that's actually not that participant's results, right? Or you might calibrate devices with a different degree of specificity or frequency. So generally speaking, there are these sort of analytical challenges of making sure if we are going to be giving results to people that sort of looks like a clinical piece of information, to make sure it meets the general standards that are expected for clinical purposes. And there's actually, this is a widely debated issue still, but there's clearly a role here for thinking about the way CLIA, which is sort of regulation that makes sure that when a patient gets results, they're going to guide their care, that is in fact their result and that it was generated in a technically correct way. There are ways to think about return of research results where they actually are subject to CLIA, right? It's really a matter of thinking about, are we returning these results for the purpose of providing information for diagnosis, prevention, or treatment? If we're not returning results for that purpose, what is the purpose, right? So you will see folks who say, no, you don't need to follow CLIA in this context. And many folks say, well, people are going to go take actions based on this, so that sure seems like CLIA applies. Okay, clinical validity. So the relevance of findings to human health exists on a spectrum, right? So there are things that research could generate that look a lot like a clinical test, right? We know this is valid and useful in a clinical context to answer or guide clinical care. And there is a sort of evidentiary basis for making those conclusions. But there's a lot of information that's sort of relevant to our health. It's interesting, but it's not clear exactly what it means for a person's health. So I picked out just kind of a random example, microplastics, right? See a lot of discussion in the media about microplastics are everywhere. We all have microplastics in our tissues. What's the relevance of that to human health? Surprisingly little is known about that, right? So if I was participating in a research study and the investigators told me, hey, you've got a high level of microplastics, I don't know what that means. I don't know what I should do. So thinking about how these results have sort of what we would call clinical validity is really a key issue. Okay, actionability is another key challenge in disclosing research results to folks. So we know some results are analytically and clinically valid, but there's no known actions that can be taken to prevent or mitigate outcomes. So great example of this is certain genetic variants that we know that's a real thing. We know it is associated with risk for disease. Is there anything an individual could do in response to that to decrease their risk? That might be quite unclear. That's not to say that these kinds of things can't be returned to folks, but really thinking about what is the context we're going to put around that for folks so they understand what that means is really critical, especially when you think about, if you gave me a result that I'm at risk for a particular genetic condition, I might go out and change things in my life that sort of carry their own sets of risks. And so maybe that was a bad idea for me to do that. It's not going to help me any, right? So thinking about when we're disclosing results to folks, is this actionable? Are we sure that's going to help? How can we help folks think through that? Okay. And finally, access is a key issue. So research participants may get results that say, hey, you're at risk for X. It's a technically valid result. We know it's relevant to your health, and we know there are actions that can be taken in response to this that would improve your health or decrease your risk. But maybe the participant doesn't actually have access to those things that need to be done. So I'm at risk for developing a neurological condition. I need an MRI. Well, maybe I'm uninsured. I can't get an MRI. So I think any effort to disclose research results to individuals really needs to take into account the idea that there are things that could be done, but I don't know if people are actually going to benefit from that. And arguably, research studies do have some amount of responsibility to do some things to help with access. So that's a whole debate in itself about what is sort of, we call this ancillary care that goes along with being in research. That is the responsibility of the research study. But it's at least access to someone who can explain the results seems like a key thing to make directly accessible through the research study. And, if the results are sort of not done in a CLIA way, or they have sort of technical validity that's not at the standard that's used for clinical care, maybe you need confirmatory testing that's made available through the research study. Okay. So let's talk about some solutions. Again, getting back to that, how should this be done? I think it's really key to think about how we can really demonstrate transparency and reciprocity while making some results more visible than others, right? So we're sort of acknowledging the right of participants to have access to information about themselves, but that doesn't mean we're sort of putting information right into people's faces that is unuseful, right? We're trying to highlight, this is the stuff that seems most useful, this is the stuff that's less useful, and we're trying to create process around that, right? To bring visibility to the most useful results. So, you can use tools like a web page or an app, or you can incorporate these results into something like an EHR's MyChart. You can provide it with context and explanation tailored to the participants' results, as I was saying, and you can even push notifications to folks. Hey, want you to know there's something here we think is useful to you, right? So you could do that for the most valid and useful results, and sort of not do that for the things that are less important. So I just wanted to give you 2 examples of groups that have done interesting things around making research results available to participants in a way that maximizes their use to folks. So the first one is the Emerge Network. They're currently basically doing genetic testing on research participants. They're calculating a polygenic risk score, and then they're sort of providing that back to participants along with estimates of their risk based on family history and other kinds of relevant pieces of information. And they're kind of assembling that into a general sort of report about risk for whatever condition. Derby comes from a slightly different perspective from the environmental exposures. And this is basically an app designed to make it possible for participants who participated in research that's measuring environmental exposures, maybe, industrial, pollutants, et cetera, to give folks like, hey, we measured, X pollutant in your neighborhood, and this is the result, and this is the context around it. So similar kinds of challenges, but different kinds of information. Okay, so then we think about these results that have less validity, less relevance to the participants, but folks will want that sometimes. So you could make that available for those who want a deeper dive, maybe even by making it request only, sort of, this is the stuff we want to make sure you have. If you want anything else, let us know. We'll send it to you, right? This can be a challenge in a number of ways. Because of this CLIA compliance question, there are research organizations who will say, no, you can't give that to participants. Their lawyers will say that, right? Because, sounds good, you're not following CLIA. So yeah, and these results can be very numerous. So giving the necessary context can be a challenge. Okay, and then just, this is going to be my last slide, I think. There are some results that folks will not want to look at, right? Maybe someone who has a family history of Alzheimer's specifically is not ready to look at that information and doesn't want to get it. So building in a way for folks to sort of control what information they see is critically important, I think. Okay, and we can discuss these issues in question and answer. Yeah.
Great. Thanks, Kyle. Much appreciated. Lots to dissect for return research results, and I promise we will get into it. Our last speaker is Kareem Watson from All of Us Research Program.
Thank you all so much. It's a pleasure to be here. I'm excited to talk about this and engaging participants as partners. Prior to joining the NIH, I spent 17 years at the University of Illinois at Chicago at UIC as a cancer disparities researcher, trained in community-based participatory research, CPPR. And so I also was a faculty member in the School of Public Health, and I often tell my students when I'm teaching community engagement, there's 2 important measures you need to know about teaching community engagement. I said, as a faculty member and as a community engaged researcher within the academy, there's a power dynamic of inequity. I said, so 1, you have to develop this thick skin because there's going to be some pushback from the community. And I would tell my students, if you don't get pushback from the community, you're probably not doing community engaged research right. Because in order to get that pushback, you have to create space for that feedback to happen. So I just want to ground this in that work. And also I'm reminded about the concept of knowledge dissemination, and how we get this information back. And I learned from some citizen scientists that I was engaging, a group of barbers on the south side of Chicago, that said, and I was so excited to include them as authors on a publication. And it was like, that's great that you're including us as authors, but how are you going to get this information back to the community members? And so it was their idea to go back to the places where we collected the data and go back and return that same information. So we went back to the churches where we collected information and recruited and engaged those men. We went back to the barbershops. We went back to several places to return that information through this concept called knowledge mobilization. I'm going to talk about that all, but I want to ground it in that because that's something that I learned from my participants who are my partners. So the All of Us Research Program, I'm very fortunate to be the Chief Engagement Officer for the All of Us Research Program. But prior to joining as the Chief Engagement Officer, I was actually one of the co-investigators for the program. So I had the privilege of going around the country for about 2 years, engaging with what we called engagement studios. And these engagement studios had over 300 participants that, they weren't participants at the time, but 300 community members that lent their voice to tell us how they wanted to see the nation's largest and genomic study conducted and developed and informed. And one of the things we heard was that we have to think about access. We have to think about location differently. We have to think about moving away from the ivory tower where research is conducted, knowing that most research, particularly clinical trials, are conducted in academic medical centers. So the community member said, we need to see this research conducted in our communities. So we partnered with federally qualified health centers as a result. So prior to the launching and enrolling of our first participants, we actually engaged a group of FQHCs. Why? Because we know that a lot of Americans, a lot of people get their care at FQHCs. However, they're often not included in research because research is often conducted in academic medical centers. We also thought about rural America and places that took care of people that are part of populations who've been historically underrepresented in biomedical research. There's growing qualitative data that exists that although it's true that there is justified medical mistrust when it comes to certain populations discussing clinical trials, but that justified medical mistrust is not the biggest barrier to participating in clinical trials. The biggest barrier for populations historically underrepresented in clinical trials from participating is access and awareness. They often get their care in community centers where there's no clinical trial being conducted, or that primary care doctor has so many other things to deal with that that participant or patient's never been offered a clinical trial. So we want to really level set this conversation of where the role of justified medical mistrust sits and where this concept of access, education, awareness sits. And I show this slide to say that this is an example of how we've tried to ensure that most people have access to enroll in the All of Us research program. Today, our goal is to enroll over 1 million participants who represent populations who've been historically underrepresented in biomedical research. And unlike some research programs where you're trying to see if drug A differs than drug B or if intervention A is better than intervention B, we're looking to collect data from 1 million or more people and to make that data readily available to researchers, but also to ensure that that data that is available to researchers has been informed, that use has been informed by participants as partners. And today we've collected enrolled over 800,000 participants and have electronic health record information from over 400,000 participants, biosamples from over 500,000, and then participants who have completed the initial steps over about almost 600,000 participants to date. And you'll see this highlights where we've enrolled our participants. And I also want to point out what happens when you do effective community engagement. When effective community engagement is done, you will see results that demonstrate that that engagement has happened. So the bottom pie chart shows that most genomic studies where we're getting these polygenic risk scores from, where we're getting all this amazing science happening, most of that science is built on populations who don't look like the rest of the US. So 94% of other genomic studies have participants who are from European or white ancestry. Whereas through participant engagement, site engagement, and rural engagement, we now have over 46% of our participants in the All of Us research program are underrepresented by self-reported race ethnicity, where we have over about 20% of our participants 16% of our participants, who self-identify as Black or African American, about 17% as Hispanic or Latino, and you'll see other. We even collect information around Middle Eastern, Northern African metadata because why do we collect information? Because when we were doing our community engagement listening sessions, populations let us know that we need to be seen in this research. Now, I do want to highlight that one category that you do not see on this slide right now is American Indian Alaska Native data. And that is also because of community engagement, because we know that that data will be presented and those numbers will be presented, but we had to go through a series of listening sessions and tribal engagement to make sure that we're doing that the right way and how we will classify and present that data. So that hopefully that will be coming out in the fall of this year. But I also want to highlight other areas of intersectionality. We heard that word earlier today, right? And so people don't show up as a monolith. We don't just show up in my identity. We come to the table with many different identities. And so it's so important to make sure that we include and underrepresented populations. So 1 in 4 of our participants is from an underrepresented group. 1 in 5 of our participants is living with a disability. And over half of our participants are born female at birth. This is important, and also 1 in 4 of our participants are greater than 65. Why is this important? Because again, these are populations who've been historically underrepresented in biomedical research. Another thing that I used to tell my students is that another measure of true community engagement and listening to your participants is that you must do something different based on what you heard. If you're not doing anything different based on what you've heard from the participant or the community, that's not necessarily true engagement. It's definitely not engaging participants as partners. Something has to change. So that was often a difficult concept to convey to research students because they would have these rigorous protocols and they would say, Kareem, well, Dr. Watson, how can I be so nimble? The community said that they wanted this. I said, it's called an IRB amendment. That's what the IRB is there for. It's there to amend your study, to amend your protocol. There's ways that you can incorporate what you hear from the community to be nimble to that. For example, we collect social determinants of health data in the All of Us research program. We collect over 27 questions on SDOH. It was through participant partners that who engaged with Dr. Cheryl Clark that said, we want to change the way you're asking about religion and spirituality. Because at first we used a validated survey and asked it in a very simple way. They said, no, we actually want 2 questions in here about that. And because it's important to understand how where we live, where we play, what we believe, where we worship, how that and our spirituality, it has outcomes in our health outcomes. So our social determinants of health questionnaire was changed as a result of that. We also collect data, a wide variety of data, not just survey data and biological data, but we collect Fitbit data as well. And that wearable data was such an important thing to hear from the participants because one of the things they said to us is make sure you're addressing the digital divide. And this was an issue for us. So because we know that most people who have a Fitbit come from a privileged lifestyle. So we made sure to partner with an organization that was able to give us Fitbits so we could give them to participants for free so that we could address this issue of access. Next, we adapted an ecological model to think about community engagement. And you'll see from these awardees on the right that the majority of our partners, we have over 18 national community engagement partners that help us operationalize this ecological model of engagement that talks about outreach and awareness, education and access, enrolling to engage, to enroll and retain, participants as partners, the purpose of me being here today, and knowledge mobilization. Again, moving beyond this concept of dissemination, publication, but truly mobilizing knowledge. And our 18 partners help us do that. And I'll end with talking about a way and how we operationalize that. These are examples of how our partners, our national community engagement partners, along with our participants, have helped us operationalize this ecological approach to engagement. The National Baptist Convention USA, because we know that faith-based partners are still a very important community entity in certain communities. So National Baptist Convention USA is one of our national partners. They helped us to reach over 31,000 participants, 31,000 community members in faith-based institutions. And in 2023, they reached over nearly 20,000 community members. Through education and access, the University of Utah is helping us think about who are these teachers? How are we engaging science teachers? Thinking about the next generation of data scholars and data scientists to think about this work. And then enrollment and retention. The National Alliance for Hispanic Health has been an amazing partner for us. When our program launched, it launched in both English and Spanish. And that was in large part due to the voice of the National Alliance of Hispanic Health at the table with us. Next is participants as partners. We have over 45 participants from the All of Us research program that sit in various roles of governance throughout the program. And I'll highlight that for you in the next slide. And then lastly, knowledge mobilization. I just published an amazing paper on the work that I did in Chicago with barbers and citizen scientists. My family did not read that paper, but seriously, real talk, that happened. I went through the family chat, but I guarantee you if I had put that work in Essence Magazine, where my sisters read, or put that work in some other venue, we would have mobilized knowledge and my sisters would know more about the changing landscape of when certain populations should be screened for colorectal cancer. But so we have to think beyond this concept of publication and even research talks when it comes to knowledge mobilization. And Dr. Liz Cohen through the Ignite program is helping us do that. She has what's called data sandboxes, where she takes our data and presents them to community members and said, this is what the All of Us research program has found about condition X. What does this mean to you? What research questions do you want to see asked as a result of this? These data sandboxes happen throughout 8 communities across the US, and we hope to continue those. And here's an example of our governance structure. You can learn more about our participants as governance partners through these 2 QR codes. This is a story of Ray Charles, one of our participants who was a strong advocate for the program's planning and training of staff. Ray was instrumental in making sure that we had staff that were trained and ready to receive participants in a way that was not a turnoff, right? Ray talked a lot about what are you doing to make sure that the staff is ready to go over the consent form with us? If it may take longer than 30 minutes or 45 minutes, is the staff training. So we had a participant at the table helping us with that training. And as you can see here, from being a part of our advisory committees, to our IRBs, to our survey development, even to how we think about how we disseminate our findings, we have participants and partners at each of those stages. And this work is actually funded through an Engagement Core Award through Dr. Consuelo Wilkins at Vanderbilt University that helps us to oversee this work. We even have co-chairs. We recently launched ancillary studies, and from those ancillary studies, that's going to be studies that come and ask different questions from our data. We have participants helping us to say, this is the type of ancillary study we want to see asked. This is what's important to us. And I'll end with some work that I was doing in Macon County on community return of value. We did a survey of over 22,000 participants in the All of Us research program, because this concept of return of value was, Dr. Brothers, it was tough for me because I kept asking the program, whose value? We keep saying return of value, but who has said this is valuable? What have the participants said is value to us? Getting this information back alone may not be valuable. So we have both the return of value information, which is return of data, but through community listening sessions, we found out that you can't just return even actionable findings, right? We can't just return actionable findings without connecting those participants to additional resources. So every participant in the All of Us research program who gets an actionable finding has the opportunity to meet with a genetic counselor for free. And I know that because I'm a participant in the program. So when I got my genetic information back, I was no longer Dr. Watson, the cancer disparities researcher. I was Kareem Watson, the son of Tommy Watson, who died from colorectal cancer, and the brother of Wayne Watson, who also died from colorectal cancer before the age of 60, excuse me. So I was scared when I got my results back because I wanted to make sure I didn't have a condition called Lynch syndrome. And I'm thankful that I had a genetic counselor to walk me through how I communicated not only my results to my other family members and children, but how I communicated those results to my primary care provider. That's what we learned. And I'll end with talking about the work in Macon County, where we went to Macon County, which is in Tuskegee, Alabama, to talk about the importance of addressing medical mistrust head on. And one of the things that we found out in our work with Macon County is that community engagement is not a destination, it's a journey. We are continuing to have conversations, continue to mobilize partners there and engage them. If I would have did this talk 2 weeks ago, I would have said that we co-developed this project with the community members in Macon County. But recently they said, Kareem, I don't know if y'all co-developed this with us. It was close, but it wasn't true co-development. You developed most of it and we had a lot of say in that. But 2 weeks ago, I would have said we co-developed this. But through that community discussion I had with them, they said, it was close to co-development, but it was not full co-development. They said, you can't co-develop via Zoom. You need to come down here. We need to see you more. We need to see you in the community more. So I'll be back in Macon County to hopefully co-develop this next round of this work. But I want to thank you all. I'm going to skip to these slides. I know we have less than a minute left talking about the return of value, but this is just the information that we return. But the key here to the returning information about hereditary risk findings, but also the medicine in your DNA report. And in this medicine in your DNA report, I want to highlight two of our community partners. Two of our community partners talked about when they got their medicine, their DNA results back, it was a game changer for them because they were able to go to their primary care doctor and say, if I were to have a stroke, if I were to have a cerebrovascular incident, I metabolize this particular drug differently. So you need to understand what dose I may need to get for that drug. They were able to have that conversation because of the medicine and DNA report they got back. Hugo Campos, one of our participant ambassadors, who said, I'm going to read his quotes. He said, I wanted the genetic test done. I wanted to learn about genetics. I wanted access to genetic counselors so that to me, it was very valuable. That alone was my personal reason to join the All of Us research program. And again, this is information that we would have never got had we not engaged our participants as partners. I encourage you all to go and scan and learn about Michelle's story and the amazing work that she's done to make us be a program that is truly accountable to the participants we serve. Thank you all so much for your time. I look forward to questions.
Thanks, Kareem. I wasn't kidding when I say we had a great panel here. All these were fantastic talks. I will tell you, I've been writing questions the entire time. That's what I've been doing on my computer. I'll encourage everyone here in the audience to get up though and come to the microphones because you don't want to just hear me asking questions. I also know Tam is monitoring in the chats to make sure that we're going to get questions in from the audience that's on virtual. So please come up, ask your questions. While we're waiting, I will go ahead and launch in. So, if I can just say, I love the idea that community engagement is not a destination, it's a journey. That's a great quote, and I'm going to start using it, Kareem. So sorry, I've just stole that from you. But one of the things you talked about was that one of the barriers to having individuals participate in clinical trials is there isn't enough time or awareness or education for clinicians to be able to help inform. So what can be done to support a clinician's ability to inform their patients about opportunities to participate in clinical research?
Thank you for this. I think the same way we talk about co-developing these solutions with participants and with patients, we have to co-develop it with clinicians that are not clinician scientists, that are not the researchers. So we partnered with the NMA, the National Medical Association, and we said, how can we make research not invasive to your work? And they talked about ways that we could better utilize community health workers, ways that we could better utilize medical students, ways to utilize the waiting room to educate participants about it, and then making sure that we communicate to primary care providers in user-friendly language what we're doing in the All of Us research program. Members of the National Medical Association were very clear. They said, Kareem, the last thing you want is for one of our patients to come to us and we have a trusted relationship with that patient. That patient comes to us with this consent form from All of Us and says, I was asked to be a part of this study. Do you know about it? Should I participate? She said, right now, I'm going to say probably not because I don't know about it. So we did a series of provider education as well, provider workshops where he's providing CME, partnering in that way. So the similar way that we partner with participants and community, you have to partner with providers in a way as well. And when I say providers, I'm not talking about providers that are researchers that are rolling their sleeves up. I'm talking about those providers that say, I don't want to necessarily do research, but I know my patients one day might be a part of it.
Fantastic. These are open questions, so if anybody else wants to add in, please. I think the idea is to give take-home lessons to everyone here. Learn from what you guys are doing.
Yeah, we've asked our community of patients why they're not participating in clinical trials because we've realized there's a lot of resistance. And similar to Kareem, what we learned is they do want to participate. They're not getting the information. They want to be actively involved in determining what endpoints matter to them. So it's not just clinician, investigator determined endpoints, but it's what patients prioritize. And they want to be actively involved in understanding how to make a consent. I think this consent form issue is something that's really important for us to address because the minute they see that 50-page consent form before participating in a clinical trial, they're just stumped. So we need to do education about what happens during a clinical trial at all phases. What happens, they asked us, what happens if I develop an adverse event during the clinical trial? What happens if I'm underinsured and from an underrepresented community, I take the medication, the clinical trial closes, I don't have access to that same medication and I'm doing well on that medication. What is the extension period of a clinical trial? So these are the things that we need to educate our patients on in order to invite more participation in clinical trials.
Just to expand on that one last point though. So, I think you're right. People come in, they see these really long informed consent forms. It's something that the community has been sort of pushing back on for a long time. How much more do we throw into consent? Is it meaningful anymore? So I'll throw the question out. How do we actually move towards a new modality of informed consent that improves understanding, improves retention of that information that we're trying to get across?
So one of the things that we've done is participatory work, right? So you participate in creating the consent. So we gather together or convene a patient advisory board along with the investigators. And then we also break up the consent in chunks so that you're not reading a 50-page document. You're breaking up the consent. You can deliver it either in an animated way. You can deliver it in plain text. You can deliver it as a quiz so that it's interactive and so that you you gather information from the patient about what they're understanding and what they need more information on. What you don't do is what we've learned from the patient community is give the patient a document and say, here this is, go read it, let us know if you have any questions, because it's not going to happen and it's not going to work that way.
Tim,
First of all, it's
that is not working.
it's working.
Yes, perfect.
First of all, I just want to say thank you so much for the great presentations. And we have a questions actually from a former panelist, Dr. Quarles. Great presentation, Dr. Wilson. I am curious if you receive any pushback from the academic centers about following the advice and input from your community partners.
Yes, I did receive pushback from some academic centers, and I had to own what part of that pushback was our fault too, meaning it was our fault in the program. For example, the downstream of effective engagement is not enrollment. And that's really interesting because there's a difference between community engagement and recruitment. The downstream of effective recruitment is enrollment. But if you want to engage a particular population, they may not enroll. That's a hard sell to a site who's getting funded to enroll participants. So when I go to those sites and talking about what true community engagement is, and they say, wait, you're a cohort building program, so we have to enroll 1 million or more participants, but then you want me to do this engagement. And I say, yes. And I'm going to help you do that engagement and provide resources for that engagement. So yes, we got pushback, but we have to do it.
Please introduce yourself.
Oh my gosh. Hi, I'm Caitlin Esposito. I work with the Bobby Jones Carrie and Springer Maelia Foundation. And I apologize in advance because it sounds like you walked away from it, but I do want to go back to the consent situation. So as far as returning value, like research value, is that something you are, as a practice, including in your initial consent? Or is it something like you talked about high and low validity and relevance? Is that something you would like identify in the initial consent conversation? Or I would argue, is this something that maybe we kind of move towards just like an ongoing, I mean, it is an ongoing process, but really more strategically and systematically so we do consent, especially with data sharing. It's something we have to constantly iterate. So I wonder just, I guess, your ideas about where we go with informed consent in the future.
It's a really wonderful question. So over time, as we've been sort of like figuring out how does a research enterprise get results back to participants, lots of things have been tried. And if someone comes to me and says, hey, I've got some information for you about BRCA1. Do you want to know that information? I'm going to say, hell yeah, you better tell me, right? You have something about me, you better tell me. So I think that, one way to do this is to say at the beginning, are you going to want this? Because if you ask it at the beginning, then you can just not even look, right? That way it's not a situation where I know something and you know that I know it, but I'm not going to tell you, right? Because then it's sort of like, if at the beginning you decided, I don't really want to know my BRCA1 and 2 thing right now, maybe someday, but not now, then the fact that the study knows it or my healthcare provider knows it sort of takes away my opportunity to choose, right? Because now I'm like, okay, well, now I've got to find out. So there is an advantage to doing that. But doing that at sort of the level of granularity that lets people sort of get what they want is very difficult. So there are a lot of studies that use sort of, hey, there's this group of things we will be willing to tell you. Do you want it? Yes or no, right? Instead of like a one at a time thing. The other way of doing it is sort of having these portals that sort of give people a chance to sort of click into things or not to click into things, right? And then you're sort of creating this ongoing opportunity for people to choose what they want to look at and what they don't want to look at. And again, that does have the drawback that it's there. So can you resist looking? But the advantage of that is that maybe I'm not ready now, but maybe I'm ready later. And so I'm not sort of locking myself into a decision. So yeah, and I think folks up here can talk about what they actually do. So yeah, I think there's justifications for doing it different ways depending on the situation.
And I'll just throw in, just from a regulatory standpoint, the revised common rule does actually require in the informed consent document a notation if you were planning to return information. So that is one of the new changes from the 2018 revisions. But we'll go to the questions. Richard.
Yeah, thank you all. Really wonderful presentations, very thoughtful and things to consider. My question is, as a person that works for a federal agency and we fund research, what are your thoughts, and this is, for anyone, your thoughts in terms of when you're dealing with community engagement, the fact that if you're funded by the NIH, how you communicate or engage your communities when you're representing an agency that where there may be standing mistrust versus trying to build your engagement. And also if you have comments, if anyone has comments in terms of representing a pharmaceutical agency versus the federal government. What are your thoughts on that?
And again, represent another federal agency. That's why I highlight the work that we did in Macon County. As a chief engagement officer, I oversee the return of value. As I could not have a conversation about return of value and know the atrocities that happened in Macon County with the United States Public Health Service study of untreated syphilis in the African-American male. I even call it by the full name because saying the name lets you see the history of that study, the United States Public Health Service study. So I couldn't come in as an NIH federal employee and not acknowledge who funded that study. And so it was through this conversation, this transparent conversation, that we had to become more trustworthy as an organization. So just naming that piece of it was one of the things that helped us, and then understanding how we could use the resources that we had to build capacity and to leverage sustained conversations that are taking place. And so we still have conversations that are taking place right now through organizations that are funded by partners like Delta Research Education Foundation, which is the not-for-profit arm of the second oldest sorority, African-American sorority in the country. So doing creative things like that where the conversation can happen, continuously happen, is one of the things that we've tried to do creatively.
Yeah, and it's such a good question. And we work with the industry as well, so pharmaceutical companies. And we've realized there's a lot of erosion of trust. And part of our task is also to rebuild trust in institutions. So, I'd see what it takes is years and years of work, really. As a patient advocacy organization, we're in a very unique position. So that position is what we leverage. So we're not endorsing any agency. We are not endorsing any company. What we have front and forward always is the interest of the patient. And that's what we've always communicated to the patient community throughout the years. And so based on that kind of, we know our patients individually, many of them. And so it's also word of mouth. When one patient testimonials are very powerful. So when one patient says to another patient, hey, I'm taking part in this research study, it's really good. The investigators are really walking us hand in hand. There is, again, a mobilization that happens in the community that is very organic. And so, during the pandemic, the CDC approached us and said, we need to communicate the urgency to take the vaccine, the COVID-19 vaccine, for the chronic disease community. And so we worked with the CDC to put together a panel of experts, patients included, to talk about the vaccine, address the fears, address the myths, not hide any of those, of those fears, address them head on, and thereby build more and more trust.
Thanks. And just to add on, I think shining a light on the past misdeeds in the research and in the research community are necessary. I mean, we certainly can't sweep it under the rug, and we should not be doing that. We really need to say, look, this is what we did. Here's what we're doing to make sure it never happens again. And those are important things that we're doing. We've got a partnership, as Kareem's been working, I've also been leading a partnership with the Voices for Our Fathers Legacy Foundation, which are the descendants of the gentlemen who were experimented on in the USPHS study of untreated syphilis in the Negro male in Tuskegee and Macon County, Alabama. And I too also only ever say the entire name for the exact reason that Kareem actually mentioned. But it's important to make sure that we actually hold these up and say, oh, look, this is what happened out of this. And at least in that particular instance, I can point to it and say, look, that led to the passage of the National Research Act, which set in place the Belmont Commission, which then led to the Belmont Report, eventually to the Common Rule, and our setting for an ethical research enterprise for how we actually have individuals participating in research nowadays, to make sure that those things don't happen again. It makes sure that we are vigilant to make sure that they don't. So, and it's remembering it's those partnerships that are essential to make sure that we are held accountable. And it's something I mentioned at the very beginning. How do we make sure that the research enterprise is held accountable? This is part of it. So this is going to be our last question because I was already given the end note.
All right, well, I apologize. It's really not a question, it's a comment about the consent discussion we were having. So I'm part of the All of Us research. And thank you, Kareem, because the reason that I thought I was part of the All of Us research, you blew away. I now know why I'm part of the All of Us research, and maybe you can guess why. But the consent form was so easy. It was lengthy, very lengthy, but it was presented in a cartoon educational format. I had to take multiple tests, and I had to go back and take them and read the cartoon again when I got it incorrect. When I received constant, I was told that if you don't want the results, you can change your mind. At one time I said I did, and another time I said I didn't. I would get emails saying, hey, we're in 30 days, we're going to give you your results. You can still change your mind. And I compare that to, I was also in a clinical trial during COVID for the COVID vaccine. And I'm from Chicago. It was at the University of Chicago, and I drove down there, and it was a 50-page document that I didn't read, that I just signed. So I appreciated everything you're doing around the consent form. It really made it user-friendly.
And I have to thank the LC community for that consent form, the ethical, legal, and social implications. And there's a lot of policy work, and the community participants. There was almost a years of work around that consent form process, and community members said that you have to have this feedback loop and the test. And even in Macon County, when the consent form came up and some participants said it's too long, several community members set up and said, we are not going to let Kareem and that team shorten that consent form because we want the length, and they didn't want the time, but they wanted the way that it was user friendly. But there's always room for improvement. But I will say that a lot of work went into that because it was participant and user experience led development of that consent process. And I should say process and not the form.
Yes. Yeah, consent is a process. Just want to ask everyone to join me in thanking this great panel. This is phenomenal. Amir, Kyle, Kareem, Shilpa, thank you so much.